Hi there, my name is Sira Boats with Boats Memory Method. I'm a dementia consultant, I'm a daughter of dementia, and we are here to bring you hope on the dementia journey. And today we are going to talk about hospice and palliative care while on the dementia journey. This is something we are not talking about enough. And I'm very pleased to introduce Cindy Capen, a very experienced hospice nurse. And I'm going to give it over to Cindy.
Thank you. I appreciate the opportunity because, as you said, there is a lot of need that is unmet. So I'm Cindy Capen. I'm a nurse of 50 years.
Wow.
And the last 10 years of my career I spent in hospice care and learned a lot that I feel is important for people to know.
Yeah, I think that's something that either we don't know enough about end of life, entering into palliative and hospice care, or we are too scared to talk about it. So it's definitely, I thank you for being here and opening up this conversation. So I'm so excited for us to have a conversation about this. And my first question to you would be, why are you so passionate, first of all, for persons, any person, but especially seniors and their loved ones, to be self-advocates during their healthcare journey?
I read an article a few years ago that spelled out the number of people that would say that they would like to have their care at home, that they are tired of the healthcare journey. But most people do not get to die at home. They do not, they have care that they would rather not have. And I think it's because, or clearly it is because, they defer to their physicians to make their healthcare choices for them. And there are flaws in that logic.
Yeah, absolutely.
That people need to understand about.
Yes. Can you explore that a little bit and kind of let's first start and lay the foundation on what's the flaws of healthcare as we age, and especially as we're facing maybe a terminal condition or a chronic progressive condition. There are certain flaws in healthcare, the way it's situated, and you have so lovely and clearly explained it to me, and so I'd love for you to unpack that for the audience.
Physicians are armed these days with a great many tools. They are also under a lot of pressure to generate income. They're also under a lot of pressure to interpret what is the best thing, what families or patients want. So deferring to a physician to make the decision is running the risk that they have a conflict of interest when they order more and more tests or more and more treatments, that they are able to make a morally correct decision for everyone, and that they can be brave enough to say, if it were me, I would not do this. Or if it were my mom, I would not do this. Because we're a lawsuit-happy society, and physicians get sued for things like not offering care that someone later decides they should have offered. So if you as a patient or as an advocate for someone that you care about can ask the questions, what would this be like? And what is the gain for this treatment? And can I just stop? What happens if I just stop treatment? I'm tired of running around and getting all of this treatment. Can I just stop?
Right.
Could I have a palliative care consult? So I have another opinion about what's best for me and my choices.
I love that statement, and I loved what you said before about the difference between continuing on pursuing the next thing when you have a chronic disease versus having the courage to step back and take a break. Can you just kind of talk about the value for patients to just stop and take a break, and maybe some of the questions they should ask themselves at what point in that journey, when they're pursuing treatment for cancer or for a chronic disease, or they know in their hearts they're probably not going to get cured, but at what point do you advise somebody to stop, and then what type of questions should they ask themselves? And then we'll take a little bit of a turn and talk about what's palliative care, because you put that word out there, and I know a lot of people are saying palliative care, what's that? But at first I would love for you to just let's take a step back and talk about the type of questions somebody has to ask themselves when they find themselves on this journey, healthcare journey.
So I think the most important question is this quality of life for me? Is this really how I want to be using however many minutes or hours or days or weeks or months or years that I have left on this earth? Is this making a difference? Or am I getting worse? Do I feel worse now than before I started this treatment? Is this how I want to spend my time? And also, for me, it would be, what is the impact of these choices on my family? Am I losing time with my grandchildren that is so precious? Am I asking them to spend a lot of time running me around to this appointment and that appointment and the other appointment? Am I going into debt doing this? And is this how I want to spend my money? So questions like that, just quality of life. Is this, we're all going to die.
Right.
Am I going to fight this all the way up until my last breath? Or
Which is okay if that's what you choose.
It is.
Yeah.
If that's what you choose. But the point being,
right,
make a choice. Don't let someone else make your choice for you.
And know what your choices are. You do not have to get caught in this loop of chasing the next solution, which may not be a solution, chasing the next big thing, but just take that pause to be able to take a deep breath and start asking yourself questions and allowing yourself to ask those questions, and not letting the healthcare provider push you into the next thing. And I think that's something that we, as patients, receivers on the receiving end of healthcare, we're not being empowered to do that. So I would really encourage the audience. Those are 3 things that Cindy has mentioned. She said, quality of life. What do you want your quality of life to look like towards the end? That involves time. So quality time, do you want to spend it at physicians' offices in treatments that can make you feel more ill than you are? Do you want to, or are you willing to sacrifice the time of your family to support you and to take you to the appointments? And do you have the financial resources to sustain this effort to where you're not leaving your family with debt? So these are all valid questions that we can pause and ask ourselves. And also, what is the return of investment? If I'm pursuing this treatment, what is my chances of having a better outcome than what I have right now? And having asked that questions, Cindy, you said something to me that really resonated, and that was, are you willing to hear the truth? Do you want to unpack that a little bit? And that maybe we can pivot into palliative care, and how palliative care can assist us with that.
Yes. Physicians all know that not everyone wants to know everything.
Yes.
Not everyone is willing to have all of that information. And nor are their loved ones willing to have all of that information. So one of the important things about being a self-advocate is deciding whether you really want to know the whole truth and communicating that to your healthcare providers. Lay it all out for me so that I can make an intelligent decision for myself. Physician is not you. They can only make a decision for themselves. They do have conflicts of interest. They do believe that if you have a tool in the toolbox, you should use it. But that may not be the right thing for you. So do you want the truth? Palliative care, the reason I brought that up is that palliative care is, they're really truth tellers. A palliative care consult gets you a provider who is going to look at your medical record, come and talk to you and do their own exam, and speak truth to you about what your status is, the pros and cons of the treatment choices that have been perhaps laid out for you, and what your options are. I read an article a few years ago that asked people, where would you like to die? 3/4 of them said, I want to die at home. Less than a third, less than a quarter of people in this country actually get to die at home.
Wow.
And that is because they're not seizing control of their care. So palliative care will give you truth. They will help you weigh the pros and cons of the treatment options that have been presented to you. If you are hospice eligible, they will tell you that you're hospice eligible. And so that really truly offers you the alternative to stay at home and receive your care there. Plan for a death there or plan for a death in a hospice care center. When I ask a group of people, how many of you want to die in the hospital? No one raises their hand. But that's where a lot of people die because they continue pursuing treatment.
Yes, and I wanted to ask, for palliative care, can you give us some concrete steps for someone who's listening to this conversation and wants to pursue a palliative consult? What does that look like?
It requires a physician referral. And so for many people who are asking these questions, they have more than one physician to choose from.
Yes.
And so you ask your physician to give you a palliative referral. Now, interestingly, sadly, I know people that have done that very thing and had their physician respond, oh, it's not time yet. It is time anytime you have chronic health problems and you want that referral. Where that pushback comes from, I think most often is a lack of understanding on the parts of the referring physicians. They don't really know what palliative care has to offer, but also potentially fear that that palliative care provider is going to come in and say, you have stage 4 cancer. You are not going to live because you're having chemotherapy. You might live longer. Yeah. So they maybe don't want to lose patients.
Yes.
But mostly I think it's lack of understanding. So you get a referral. And if one doctor, and sometimes you have to push back. The doctor says, I don't think it's time. You say, I want one anyway, please.
Right, right. And you're allowed to push back. So that's another message, another takeaway. You're allowed to push back. And I would say if you have good rapport with a certain physician, start with that physician. Ask that physician for a referral. I wonder, Cindy, what do you think about exploring people in your community that provides palliative care? Explore them first and then ask them for guidelines on how to ask for a referral. What do you think about that approach? How do you know who are your palliative care providers in your community? How do you investigate that?
Most of the hospitals in this country have a palliative care service. I will say most of them are understaffed. And most of them get consulted when people are actively dying. There are hospices that also have palliative care consultation services. They really are, their hands are tied in terms of being able to give you concrete help until they have a referral. They need to work hand in hand with the area physicians, and it's just considered poor form to accept a patient without a referral from that patient's physician.
You have to be referred.
Yes.
So your first step as a patient, if your doctor does not know what palliative care is or don't know or is pushing back, is to know that you have a choice. And number 2 is then find out who can provide the palliative services in your community so that you have that information ready for your physician to say, this is the agency I want you to refer me to for a palliative consult, because it may be that the physician doesn't even know where that referral needs to go. So I find a lot of times, even if someone asks for a referral, if they get, for example, as a dementia consultant, we see a lot where physicians say, oh, there's nothing anybody can do for you. But if you go in with a mindset of, I have someone lined up that I know that can help me, and I know I can access those services with a referral, then you're coming to your physician with a solution, which I think helps to negate the ability to actually walk out with the correct referral.
And that point, there are hospitals have palliative care that do consults in the hospital. But there are community palliative care providers who will come to the patient where they live. And so if it were me asking my physician for a referral, I would say, this is where I want you to send it.
Yes.
And so I think that's excellent advice. So they may not talk to me until they have a referral, but I've found out who will provide it. Also, a community-based palliative care provider is not going to be reluctant to recommend that a patient downsize their treatment,
right,
because they are less monetarily driven.
They're less biased.
Yes,
yeah,
exactly.
Because they're not connected with a certain hospital system or with a certain provider group, so there's no incentive for them to direct someone this way or that way.
Right. They're also not necessarily overbooked.
Right.
I mean, in the hospital, there are just not enough providers.
Correct.
But in the community, they have more time to spend. They are less stressed to move on to the next person.
Right. Very good advice. That's excellent. So can you explain to us what is the difference between palliative care and hospice care, and what that looks like for our audience, for our recipients of these services?
Yes. So I want to repeat that palliative care can happen anytime on a chronic disease continuum. Hospice care is the rules are set for hospice care by Medicare. Even though you don't have to be 65 and on Medicare to have hospice care, most patients on hospice are Medicare recipients, and so Medicare sets the rules. And their rules are that you have to have no more than a 6-month prognosis. That means your expectation is that you will die within the next 6 months. A lot of people have the preconceived notion that hospice is for people that are dying really soon,
right,
hours to days.
Right.
And the sad reality is that most of the referrals that come from community physicians are indeed hours to days.
Dying patients,
right.
Yeah.
They stop treatment when it's clear that this patient is dying really soon. And
right,
that's a whole other kettle of fish. But people need to know that they can have hospice when they still have months to live.
Yes.
Also important to know is that doesn't mean you have to die in 6 months.
Right.
Lots of times in hospice, we find that when people get in hospice care and they stop expending their energy running here and running there and doing all of these exhausting treatments, that they actually get better.
Yeah.
Or they get their pain under control so that they're sleeping and eating and moving. They get better. So sometimes you get referred to hospice, you get better, and you get discharged until you qualify again.
Yeah.
But hospices don't have to discharge you if you are declining, but you may well live more than 6 months if you get into hospice care because your time is being spent in a more healthy way.
I love what you're saying there. So can you unpack for us a little bit about what's the benefits for hospice? I think me and you were talking also about how if you're not a Medicare recipient, but you qualify for hospice, then you can actually be assisted through this process to be a Medicare recipient so that you then can have access to the hospice benefits. So tell me, why would I want to do that? Why would I want to make sure that I can get these hospice benefits?
So the thing that I think everyone, especially those who are 65 and over, need to know is that hospice is 100% covered by Medicare. So people that have been spending out their own money on all of the copays, on going to the pharmacy, on buying supplies, the home care supplies that you need, like underpads and Depends and
barrier
dressings, yes, the creams, the equipment. Medicare requires that hospices provide a multidisciplinary team that comes to the patient. So they show up at your door. You don't have to go to them at all. So you get physician services, nursing services, certified nursing assistants, chaplains, and social workers, all coming to help you, but also to help your family because losing a loved one is really hard. And so the counseling for them is at least as important as the counseling for the person who is in need of hospice care. Medicare also requires that healthcare supplies are covered under hospice, that medical equipment, overbed tables, hospital beds, bedside commodes, shower benches, walkers, all those things are provided by hospice at no cost to the patient. And also bereavement care for the family after the person passes away. The hospice is required to continue to offer support for the loved ones, whether that be family or family of choice, that they continue to get grief support for at least a year after the person passes away. So it's a huge package of care that is completely covered under Medicare.
And that basically buys back your time, and it puts the money back in your pocket that you've been expending on all these services. So time and money comes back to you so that you can get that increased quality of life that we talked about.
And can I add one thing to that? When I worked in hospice, we got a lot of patients referred to us in uncontrolled pain. And that's for a lot of reasons, but perhaps chief among them is that that's not the focus when you're at the hospital or you're at the doctor's office. The focus is treatment of disease. In hospice, the focus is symptom management. And so we get people admitted to us that have been in pain for months or even years that has been poorly managed. Imagine how much better their quality of life is if they don't hurt, if they can get out of bed and walk and move and eat and sleep and all those things that make you healthier and make you feel better.
Yeah, I love that. And I wanted to just come back again because palliative care and hospice care is so misunderstood. And I just want to summarize it for the audience, and please feel free to jump in and correct me. So I know that the palliative care, number one, that stands out to me is that if you're unsure on how to pursue and how to resolve your chronic condition, or maybe you know that you're facing end of a life choices, then a palliative care provider can help you have an objective assessment of your choices. What I do want to highlight with palliative care is it doesn't take away any of your access to any physicians, any services. You can have home health care, skilled home health care in palliative care, meaning access to nurses and PTs and OTs. You can have all the services that you choose. Your palliative framework is to help you get ready and be aware and well informed of choices that you can make. Do I have that correct?
You do. You have that correct.
So, but then when I get to that point where I decide I have my energy, I want to conserve my energy, I want to focus on just one network of providers and have one multidisciplinary team that is going to consolidate my care. Come to me. I am done with pursuing. I love what you said. I'm done. Put a fork on me. I'm not going to pursue all these different arms of healthcare anymore. At that point, I have a hospice consult, and they will determine if I'm eligible for hospice. You have to be a Medicare recipient. So at that point, they can also help you make those changes, because if there's a change in your condition, you can go change any of your healthcare plans back to Medicare, which then allows you to tap into these benefits. But then at this point, when you become a hospice recipient, the rest of your healthcare providers go away and you are being managed by that particular hospice agency's multidisciplinary team.
Let me add one thing that does make people nervous. If you have physicians that you love, you followed with them forever, hospice does not mean that you cannot see your physicians.
Oh, very good.
So you can still see the physicians. They will still be paid for in the same way that they were always paid for. So hospice can be supplemental to that. So some people actually even choose for their primary physician to be their hospice attending physician. And if they are willing to be on call.
The physician has to be willing, though, to step into that.
They have to be willing, and willing for hospice means that we can call you day or night, because because hospice offers on-call nurses 24/7, 365. So if I, as a nurse, go and see this patient at 2:00 in the morning and their symptoms are not well controlled and they're suffering, hospice is not about waiting until the doctor's office opens in the morning.
You need to be able to have access to that physician immediately.
So if I am a hospice nurse, I can call my hospice physician at 2:00 in the morning and wake them up and get a change in treatment, or even have them transferred into a care center if this hospice has a care center, so that they can not suffer through the night. And people with chronic illnesses know exactly what it means to suffer through the night. And that's miserable. And so in hospice, that is unacceptable.
Oh, that's wonderful news. So to recap, that information is if you want to keep some of your physicians and that physician is able and willing to accept the hospice conditions, then you can collaborate with existing physicians and hospice to manage your care through hospice. And that's great information that I think I knew, but I forgot about. So, but you have to have that conversation with your physician to make sure that he is in a position to follow your care on call 24/7. And there's some physicians who absolutely love to do that and want to do that, but then I know there's some physicians that is strictly 8 to 5 and they do not do the on-call type duties.
Or they're in a practice that's not set up to be able to do that.
Correct. Yes, they just cannot manage that.
Yes.
Cindy, this was so refreshing and informative, and I'm sure we're going to have some follow-up conversations because there's a lot to talk about, how to pursue end of life well, because as seniors we are automatically qualified and are closer to end of life. So it's something we have to talk about, whether we have a chronic condition or not. And Cindy offers a class here locally in Alachua County in Gainesville at Trinity United Methodist Church, and she starts her classes in the fall, in September, and you can sign up for it from the Trinity United Methodist website. And she offers how many weeks classes?
It's an 8-week class.
8-week class.
That we call getting your ducks in a row before the time comes.
That's right. And she actually offers 2 options, a 4:00 option, so if you don't want to drive in the dark, and then there's dinner at church, and then there is a 6:00 option. 6:30 option. 6:30 option if you are not afraid of the dark. So, and this class has been well received in the community and has been growing, and she's been adding topics to it and speakers, and just a wonderful resource here in the community. And for those of you who don't live locally, we'll bring Cindy back and have more conversations about how to get your ducks in a row for end of life. Cindy, thank you so much for joining us today. And as always, please sign up for our YouTube channel. Visit us at www.boatsmemorymethod.com. You can sign up for courses there. If you're a professional and you want CEUs, you can sign up for our free monthly newsletter that's full of resources for you monthly. And we'll see you soon.